Hi, I'm Dr. Nami Alex Samuel. I'm working as a part-time teacher in BluepenOnline, and I'm working as a diabetologist in CMC Ludhiana also. So today I'll be taking a class on shock actually. So what do you mean by shock? Shock actually is inadequate tissue perfusion resulting in impaired cellular metabolism. So the cells will be deprived of oxygen and nutrients, forcing the cell to rely on anaerobic metabolism. So there is two types of metabolism which is happening in a body, that is aerobic and anaerobic metabolism. Aerobic oxygen uses anaerobic metabolism uses oxygen, whereas anaerobic metabolism it does not use oxygen. So actually, when an aerobic metabolism takes places, there's a production of ATP, but in anaerobic metabolism there is usage of ATP. So what happens when the ATP is the energy of our cells. So what happens is that there'll be less energy produced and the cells will start going weak and it will lead to shock. And one more thing is that in anaerobic metabolism, the lactic acid is the byproduct of the anaerobic metabolism. So what happens? When lactic acid is an acid, so they get deposited in our body and it can cause metabolic acidosis, and acidosis will lead to also end organ damage and it will cause organ dysfunction. So what is most common cause of shock? So most common cause of shock which is seen in day-to-day life is hypovolemic shock. That is how does the hypovolemic shock happen? When there is loss of fluid from our body, that is mainly the blood. So that will lead to decreased blood volume. Now I'll come to a topic of physiology of shock, because you just need to understand what causes the shock formation, and when shock happens, what all the reaction happens in our body. So now I'll take into shock mainly the hypovolemic shock. When there is decreased blood in the body, there will be decreased perfusion. That is the blood supply to all the parts of our organ and cells. And when there is decreased perfusion, I told you it will start using anaerobic metabolism, because there will be decreased blood supply, and decreased blood supply because leads to decreased oxygen. So when there is decreased oxygen in our body, it will switch from aerobic metabolism to anaerobic metabolism, as there will be oxygen deficient. So when there is anaerobic metabolism, there will be decreased there will happen in the absence of oxygen, there will be decreased ATP. I told you that ATP is the energy which is needed for our body. So instead of producing energy, there will be decreased and excessive use of energy, that's ATP. And when there is excessive use of ATP, it will lead to death of there will be deficient of ATP. So when there is deficient of ATP, there won't be any energy for the cells to take up, and the cells start dying up. And one more thing is that there will be increased production of lactic acid, and this lactic acid gets deposited in our body and it causes metabolic acidosis. And when all these acidosis decrease ATP, it will stimulate there's a special type of receptors in our body which is located on the heart, and one other second receptor is located on the carotid blood vessels. There's the carotid body and the baroreceptors. So these two get activated, and they sense that there is something wrong in our body. That's what I said, baroreceptor and chemoreceptors. And then these receptors, when they're activated, they stimulate a center in our brain. There's a medullary center in our brain. So it is mainly the center which regulates the heart rate, and which also inhibits the heart rate. And one more center is the vasomotor center, the cardioregulatory center, and the vasomotor. I'll come into it in the next slide. So it is mainly the baroreceptors and chemoreceptors which get stimulated, and they send a stimulation to the brain. That's through which nerve? There's the vagus nerve. That is, you can see a pinkish color or a purple color nerve going from the baroreceptor to the brain. That is a cranial nerve 10. Cranial nerve 10 is the vagus nerve. And then there's one more nerve which is from the carotid body. That's the two blood vessels, V-shaped blood vessels you can see above the heart. That is there is where the carotid body is located, and from the carotid body there's a glossopharyngeal nerve. That is the 9th nerve, which is stimulates the cardio center and the vasomotor center. So in the next slide, you can see that the two center, cardioregulatory center and the vasomotor center, get stimulated from the lactic acidosis and decrease ATP, and it's mainly the decreased perfusion which stimulates these two centers. So once cardioregulatory center and vasomotor center are stimulated, what does it do? Cardioregulatory center has got two actions. It has got cardio-inhibitory action, which causes the decrease in heart rate, and there is other one called as a cardio-acceleratory center. Cardio-acceleratory center, which increases the heart rate and increases the stroke volume. Cardio-inhibitory center is regulated by the parasympathetic nervous system, whereas the cardio-regulatory center is stimulated by the sympathetic nervous system. And cardio-inhibitory center is it decreases the heart rate by inhibiting the stimulation. That is to the parasympathetic nervous system. Whereas cardio-acceleratory is acting to the sympathetic nervous system. It increases and causes the heart to pump more faster, and it increases the stroke volume. That is, it increases the amount of blood. Tries to increase the amount of blood getting supplied from the heart. So here, this inhibitory action gets suppressed because we need more oxygenated blood. So here the inhibitory action is suppressed, and here regulatory acceleratory action is activated. So therefore, the person with shock, he starts getting increased heart rate to the sympathetic nervous system, and increased stroke volume also. And there is a center called vasomotor center, which is stimulated along with the cardio-acceleratory center. And here vasomotor center, which acts on the blood vessels, and it causes what? It causes vasodilatation, vasoconstriction, all the vasoconstriction, and it tries to stimulate, and then it causes vasodilation. So here it is the parasympathetic nervous system which gets activated, and then it acts. You see a pink color nerve which is acting on the right atria, and it acts on the right atria, and then it acts on the SA node. It's written in green, SA node and the AB node, and this causes the increased electrical supply of the heart, and it causes the contraction of the heart. This is mainly the cardioregulatory center. Whereas the vasomotor center, it then acts on the adrenal glands on the right side. On the person in the image right side, we can see the adrenal gland, which is yellow in color, written below above the kidney. Here the vasomotor center's action takes place. It causes the release of a lot of chemicals. That's the vasomotor chemicals, like vasochemicals which causes vasoconstriction, like adrenaline, noradrenaline. It causes, and then it causes release of these enzymes, adrenaline and noradrenaline, and these enzymes acts on the peripheral blood vessels in the our limbs, in our other parts of the body, legs and all. It will cause vasoconstriction, and this vasoconstriction will cause what? On the peripheral limbs and legs, the vasoconstriction causes increased backflow of blood back to the heart. And when there is increased backflow of blood to the heart, there is increased stroke volume, and this will help the heart to pump more blood to the vital area where during the shock it requires with organs which requires more amount of blood. So it causes vasoconstriction, and when there is vasoconstriction increase, there is mean arterial pressure, and there is when there is increased mean arterial pressure, there is increased blood supply to the heart. This vasomotor function is found only in the peripheral peripheral limbs or the peripheral hands or legs, and it is not found in the heart or the brain. Remember that it is not. This vasomotor function is not found in the vasoconstriction is not found in the heart or the brain area, but it's found in the other parts of the body. So this is how the physiology of shock is. So what do you see? Signs or clinical features seen in shock. The most common clinical features seen in shock are mainly hypotension. That is decreased. There will be BP, because since there is the decreased blood volume, there will be decreased BP. And there will be, when there is decreased BP, the heart I told you will start pumping more, and it will be due to the cardio-acceleratory function. It will cause increased heart rate. That's why tachycardia will be seen first. Then there will be weak and thready pulse. Since there will be heart will be beating fast rapidly, the volume of the blood will be very less, because the heart will be beating very rapidly, and the volume of blood needed to be there will be supplied from the heart will be not sufficient, and it won't be not voluminous so much. So there will be weak thready pulse, and there will be increased respiratory rate, because of decreased oxygen in our body. The body needs more oxygen, so you start tachypneic. You start increase breathing, and it will be very shallow breathing, not deep respiration. It will be shallow type of respiration. Then there'll be pallor because of decreased oxygen supply, and there'll be decreased bowel sounds because all the blood will be concentrated into the vital organs like heart, brain, liver, like mental organs will be concentrated, and it will be decreased blood supply to the intestines or stomachs. So there will be decreased bowel sounds, and then if we don't treat and if the person does not recover, then there will be end organ damage. What are the signs of end organ damage? It includes confusion or lethargy, as altered sensorium, then cold, clampy, or malted skin. As when you're seeing on the periphery because of vasoconstriction, you find cool peripheries. That's cold, clampy, malted skin, and they'll be decreased during output because there'll be decreased. There will be volume fluid loss from the body, and because of fluid loss, there will be less fluid in the body, and this will lead to decreased urine output. And decreased urine output is the most sensitive clinical indicator. Then, what is the lab investigation which we commonly do in shock? Commonly do in shock, lab investigation includes the elevated serum lactate levels will be there, because when you see the serum levels in the blood will be elevated, then there will be acidosis, signs of acidosis when doing the arterial blood gas levels. So there will be signs of acidosis where the pH will be less than like 7, less than 7, or less than 7.2, less than 7.1. It will be the pH level, and there will be mixed venous oxygen saturation. Normally it is about 50 to 70%, but in hypovolemic shock it will be less than 50% due to the tissue extraction, and then in septicemic shock it will be more than 70%. So what are different types of shock? Different types of shock which you commonly see is the most common one is the hypovolemic shock, second is cardiogenic shock, then neurogenic shock, anaphylactic shock, septicemic shock, dissociative shock. But the most common ones, the 5 ones are the most common ones, which will be taking in the next slides. So what is hypovolemic shock? Inadequate blood volume to maintain the supply of oxygen nutrients to the body. That will be, there will be decrease in blood volume of the body, and because of decreased blood volume, there will be decreased supply of oxygen to the cells, and this will cause hypovolemic shock. What are the most common causes? Most common is hemorrhage. It can be external hemorrhage or internal. So the external through the flesh, or like following the compound fractures or cut injuries, that can be blood injuries, which is external hemorrhage, blood loss, and internal loss can be due to esophageal varices or blunt trauma to the abdomen, which can cause internal loss. Then the other type of hypovolemic shock it can be seen in diarrhea, excessive diarrhea or vomiting, like severe typhoid, severe cholera. It can be correlate to hypovolemic shock. Excessive perspiration, that is when the person starts sweating a lot and uncontrolled sweat due to some neurological problem, it can be excessive. It can lead to hypovolemic shock. An excessive shift of plasma from the internal from the blood vessels to the extravascular area, intravascular area to the extravascular area. It can cause like hypovolemic shock, especially in burns, or it can be peritonitis, which cause the hypovolemic shock. These are the most common causes of hypovolemic shock. So, like, what's the class of hemorrhagic shock? The different classes of staging of hemorrhagic shock, like stage 1, stage 2, stage 3, and stage 4. You can study this table because they can ask you, if you draw this table, you can give you a good mark actually, and they can ask you questions from it. At what stage, like blood loss of up to 750 ml is stage 1 hemorrhagic shock, 750 to 1500 ml is stage 2 hemorrhagic shock, so 1500 to 2000 ml is stage 3 hemorrhagic shock, and for more than 2000 stage 4 hemorrhagic shock. So blood volume is up to what percent? 15% stage 1, 15 to 30% is stage 2, stage 3 is 30 to 40%, and stage 4 is greater than 40% of the blood volume is lost, then it is stage 4 shock. Then pulse rate when it's less than 100 is stage 1, but 100 to 120 it is stage 2, stage 3 is 120 to 140 is stage 3, and stage 4 when the pulse rate is, when the pulse rate will be steady pulse, but it will be tachycardia due to tachycardia, pulse rate will be very high, it is greater than 140, it is stage 4. Then blood pressure in stage 1 and stage 2 will be normal, but in stage 3 and stage 4 the blood pressure will start decreasing, and even respiratory rate, they study 14 to 20 is stage 1, 20 to 20, 30 is the stage 2, stage 3 is 30 to 40, and more than 35 is stage 4. And when there is urine output, as I told you, decreased urine output is a sign of, is the most sensitive indicator of hypovolemic shock. That is, when the urine output is less greater than 30, it is stage 1, stage 2 20 to 30, then stage 3 is 5 to 50, and when there's negligible in stage 4. And the CNS is like altered sensorium or slightly anxious is stage 1, mildly anxious is stage 2, stage 3 is anxious and the patient is confused, he's not able to recognize where he's admitted in the hospital or where he's in the home or anything. And when he's fully confused, it's lethargic, that is, he can't get up from bed, he's not he's fully drowsy and all, he is stage 4. So this classification you should remember. So what's the treatment? So hypovolemic shock, most commonly we give the IV fluids like crystalloids, then ringer lactate, then blood transfusion with Paxil, that's a PCB, Paxil volume, PCB. Then you give antithrombolytic agents like tranexamic acid, because there's high chances of thrombocytopenia when there is decreased blood volume, that's the plasma and all. There will be more increased cells, and the cells can cause increased injury to the blood vessel. I can go to the thrombolytic stage. So if we need antithrombolytic agents like tranexamic acid, then you have to maintain the airway. So you should intubate the patient, treat the underlying cause of hemorrhage. So it's like when there is excessive external injury which causes the blood loss, then treat that external injury. If it's internal hemophagocytosis, esophageal viruses, banding and staple we do. Then if it is internal blunt abdomen trauma, then you do explorative laparotomy once the patient is stabilized, and you treat that underlying cause. This is the hypovolemic shock. The next is type of shock is the cardiogenic shock. So when the heart fails as a pump, then it causes the cardiogenic shock. Here, these are the following features, like systolic BP will be less than 90 mmHg or for greater than 30 minutes. Then there will be raised blood volume in the veins, increased capillary wedge pressure, that is in the blood pressure in the lungs, and increased central venous pressure. And increased central venous pressure is a sign of cardiogenic shock, where the central venous pressure is actually measured in the internal jugular vein, putting a central line, and that will help you identify. So what is the cardiac index? Cardiac index is cardiac output per minute per meter square of body surface area. Normally, the cardiac index is actually between 2.6 to 4.6 liter per minute per meter square. If it's less than 1.8 per liter per minute per meter square, it is commonly seen in MI. It's seen in cardiogenic shock, and it is seen in MI, valvular heart disease, pericardial tamponade. What is pericardial tamponade? Is that any injury to the pericardium. So inside the pericardium, there is the next layer of the pericardium is a myocardium. So any injury to the heart wall, and it leads to bleeding into the pericardium, and the pericardium is not injured, but there will be pooling of blood between the myocardium, endocardium, and the pericardium, or the heart wall and the pericardium. It leads to pooling of blood there, and finally it forms a big tamponade type. So there will be a big block of blood there. So that is called the pericardial tamponade. And then next is also seen in pulmonary embolism. So these are the four main causes of cardiogenic shock. There is a MI, valvular heart disease, pericardial tamponade, and pulmonary embolism, which causes the cardiogenic shock because decreased cardiac index of less than 1.8 liter per minute per meter square. So what are the investigations we do? So investigations we do is ECG, echo, then cardiac enzymes like tropi, T and tropi. Then what do you do? Treatment is oxygenation, then inotropic agents like dopamine, dopamine. Then we give aspirin and clopidogrel, which are antiplatelet agents and which helps in thinning of blood. And in resistant cases, we give milrinone, catecholamines, that is adrenaline, noradrenaline. The next type of shock is a neurogenic shock. Here vasodilation occurs when loss of balance between the parasympathetic and sympathetic. I told you parasympathetic and sympathetic. Sympathetic one, which is cardio-acceleratory, and parasympathetic one is cardiac inhibitory. Same in blood vessels, vasodilation is caused by the parasympathetic nervous system, whereas sympathetic nervous system, it causes the vasoconstriction. So here, there is a loss of balance between the parasympathetic and sympathetic nervous system. So sympathetic stimulation is cut off when there is a spinal cord injury. So here it's a type of a distributive shock. So here distributive shock because it's distributed between the two parts of the body, because above the site of the lesion and below the site of the lesion. So here there is a neurogenic shock means at time of spinal cord injury, here the nerve is injured. If it is injured, it is injured below the level or above, it is injured at the level of T6. If it's injured at the level of T6, there's a thoracic 6 vertebrae or the thoracic 6 spinal cord level. When it's injured, here there is destruction of the sympathetic and there is a destruction of the sympathetic nervous system. So once sympathetic nervous system is destroyed, there's only one nervous system, it's the parasympathetic nervous system, which causes the vasodilatation. So once there is vasodilatation, there will not be any vasoconstriction. There will be pooling of blood in the peripheries, and there won't be backflow of blood to the heart. So there will be decreased blood volume to the heart, and this will cause what? Decreased volume of blood, and it will cause a cardiogenic shock. That's what I told. When there is a spinal cord injury, it causes sympathetic paralysis. The sympathetic nerve is the one which causes the vasoconstriction. But once the sympathetic nervous system is cut off, there is no vasoconstriction. There is only parasympathetic nervous system, and there is only vasodilatation. So vasodilatation, what happens? Just cause of vasodilatation, there will be pooling of blood in the level of the lesion, that is the below the peripheries, in the leg, on the hands, and there will be only pooling of blood there, and there won't be backflow of blood. And this will cause the decreased blood supply to the heart, and decreased blood collection in the heart, and there will be decreased blood pumping from the heart to the other parts of the main organs, and this will lead to cardiogenic shock. So then what happens? So if it is the lesion is above, if the final lesion is above T6, sorry, at the time I told below, sorry, it is above the T6, if there will be loss of sympathetic stimulation of the heart, and when there is loss of sympathetic stimulation of the heart, there won't be vasoconstriction, there will be only parasympathetic stimulation, and this will cause vasodilatation. This vasodilatation will cause the decreased blood supply to the heart and decrease heart to contract, and there will be decreased heart rate, and this will cause bradycardia also. What's the treatment? Here, since there is no vasoconstriction, we should give vasoconstrictors like alpha agonist, then adrenaline, noradrenaline, then you should give phenylephrine. That is the these are the vasoconstrictors. Then you have to give IV fluid so that the fluid is backflowed into the heart. So increase the blood volume, and this will help in the heart to pump. So treatment. Then next is what anaphylactic shock. So what do you mean by anaphylactic shock? This anaphylactic shock mainly say following an anaphylactic reaction. Anaphylactic reaction means that's the most commonly that what is it, the allergic reactions. So it is IgE mediated hypersensitivity reaction which is caused by the degranulation of the mast cells. These are special type of cells which has cytokines in them. There's a tumor necrosis factor. Then next is the interleukin 6. These are the enzymes which are chemicals which are cytokines. They are cytokines. They are the chemicals are present in the mast cells, and these mast cells are present in the basophils. So these mast cells are released when there is IgE stimulated, means hypersensitivity reaction stimulated, and this will cause the anaphylactic reaction. That's what I told. Once these mast cells are really broken down, these mast cells contain really large amount of cytokines. Cytokines mainly histamines, leukotrienes, prostaglandins, tryptase. There's the interleukin 6, tumor necrosis factor alpha, and all those things. And these reactions, these cytokines cause anaphylactic reactions. There is sometimes anaphylactic reaction. What do you mean by anaphylactoid? As an anaphylactic reaction, till I told you now, there's something called anaphylactoid reactions. So in anaphylactoid reaction, here there is no IgE stimulation. Here directly the mast cells are stimulated of the basophil, and mast cells will release the cytokines, that is the interleukins, the prostaglandins, the histamines, the leukotrienes, and this will cause the anaphylactic type of reaction. So they are called anaphylactoid reaction because the IgE is not stimulated. So in anaphylaxis reaction, it's common seen in food like eggs, nuts, then antibiotics or vaccines, then antitoxins, then blood, then snake bite, latex. Whereas anaphylactoid reactions are seen mainly the radiocontrast dyes which are used during the CT scan or the MRI scan, then NSAIDs, then it is neuromuscular blocking drugs which cause the anaphylactoid reaction. What are clinical features seen in anaphylactic shock? So there will be hypotension, that is there will be increased vascular permeability, and will cause the leak of plasma from the intravascular area to the extravascular area, and this will lead to decreased blood volume and cause hypertension. Then there will be bronchoconstriction. Constriction, that is because there will be increased mucus secretion, and lead to bronchoconstriction and cause difficulty in breathing. There will be increased mucus production, and there will be increased GIT and bladder contractions. And what are the investigation? We do see the tryptase level increase, it will be increased, and histamine levels also can be tested, which is also be increased. But it's rarely done. Once you recognize anaphylactic reaction, going to treatment as soon as possible, because the patient may die off because of decreased or oxygenation of the blood, and this will cause breathing problems, and it causes into bronchoconstrictions, and which causes breathing problem, which cause death. So what are treatments? So treatment is, first of all, you have to maintain the airway. If there is a breathing difficulty, put IV fluids for hypertension. Give IV adrenaline, which is a drug of choice. Which is given IV adrenaline, or you can give subcutaneously or IM adrenaline mainly. Then only in very case of severe shock we give IV adrenaline. Then antihistamines like diphenhydramine or desloratadine, etc. Then we can give steroids like hydrocortisone, prednisolone, etc. The next is the septic shock. So what is septic shock? Which is mainly caused because of infection, which releases toxins, which causes the shock. What are main causes of septic shock? It can be bacteria caused, it can be a gram-positive or a gram-negative bacteria, it can be a fungi, it can be viruses or parasites, which causes septic shock. What is the pathophysiology behind septic shock? What infection due to a bacteria or a parasite or a virus, but mainly, most commonly, it's the bacteria which causes the septic shock. So bacteria releases toxins. These toxins actually it activates, I told you, the inflammatory cells like I told you, mast cells cause release cytokines. Actually here it activates the cytokines like interleukins, tumor necrosis factor alpha, etc. And these cytokines released will cause the activation of systemic inflammatory response syndrome, as SIRS. What is systemic inflammatory response? What all is included? It will be temperature will be greater than 38 degrees Celsius, or it will be less than 36 degrees Celsius. There will be increased heart rate more than 90 per minute. There will be respiratory rate of about 20, greater than 20 per minute. Normal respiratory rate is about 16-20. When there is more than 20, it is seen in shock. Then there will be WBC count will be increased greater than 12,000. Greater than 12, sorry, it is not 1,200. It is actually 12,000. Sorry, you should remember that it is greater than 12,000. So 12,000, or when there will be decreased WBC count less than 4,000. So here remember there will be increased WBC count greater than 12,000. Because normal WBC count is between 4,000 to 12,000. Here the like 12,000 depend on different labs, or it will be 10,000. Most commonly like 4,000 to 10,000 we take most of the time, or 12,000 also you can take just for now. So what is the most common sign of septic shock? There will be increased WBC count greater than 12,000, or the WBC count will be decreased less than 4,000. So sepsis, what we call condition called sepsis is a life-threatening organ dysfunction due to infection. This is scoring for sepsis as a Q-SOFA score. We say as a quick sequential organ failure dysfunction score. It's called a Q-SOFA score. So here it includes the three main components. That is the respiratory rate will be greater than I told you septic shock like SIRS, that is systemic inflammatory response syndrome. The respiratory rate will be greater than 20. The heart rate will be greater than 90 per minute. Temperature greater than 38 or less than 36 degrees Celsius. Decreased WBC count greater than 12,000 or decreased WBC count less than 4,000. This was systemic inflammatory response. Whereas sepsis, we say when the respiratory rate is greater than 22, when the systolic BP will be less than 100, that is hypotension will be there, and when there is altered, that is altered sensorial, that is when the GCS is as a Glasgow Coma scale. That is GCS is called as the Glasgow Coma scale. That score will be less than 50. So that this is the three parts of the Q-SOFA score as a acute sequential organ failure dysfunction score. That is the Q-SOFA score. That Q-SOFA score is positive. We say when there is greater than or equal to, score is 2. Greater than or equal to 2, then it is considered high risk or poor outcome. So Q-SOFA score is quick sequential organ failure dysfunction score. is mainly seen in septic sepsis or septic shock. So what are signs and symptoms? Will be warm skin, there'll be vasodilation due to the release of nitrogen. So because of vasodilation, that is, there'll be release of nitric oxide, and this will cause actually warm peripheral skin. There'll be increased heart rate, respiratory rate. That's what I respirate greater than 22. There'll be increased heart rate. There'll be increased cardiac output, not increased carbon monoxide. It's increased cardiac output. Remember, CO here I've written is increased cardiac output. The patient will be restless and anxious because he will have decreased oxygen supply to the peripheral, the parts of the body, and this will cause the patient to be anxious. And there'll be it will lead to also hypoglycemia, because when there's infection, more of the energy is utilized and more of glucose is utilized by the body, and it can cause hypoglycemia. What an investigation done? CBC is done as a complete batch cell count. Then we do CRP, that is C-reactive protein test. Then we do blood culture to find out what type of organism, if it's bacterial or fungal. Then we do serum lactate levels to find out whether there's what lactic acidosis. Then we do arterial blood gas level to find the acidosis. So what do you treat? What's the treatment for septic shock? Antibiotics is given, as triple therapy can be given, the neomycin, bacitracin, and polymyxin. Then activated protein C, that is drotricogin alpha, is given. It's an inhibitor of factor 5A and 5 and 80. Sorry, it is inhibitor of factor 5 and 80. Then you can give mannitol to increase the blood volume. Then you have to give aspirin to prevent coagulation of blood. They are antiplatelet and antithrombolytic agents, though they will help in decreasing the thrombosis formation. Then you have to give NSAIDs, that is non-steroidal anti-inflammatory drugs, so that they can reduce the inflammation, because this is a warm septic shock, is a warm type of shock, not a cold shock. It's a warm type of shock. So there will be a lot of inflammation and redness. So to reduce that inflammation and redness, you have to give NSAIDs. The patient will be having pain and all. You should give NSAIDs. So this is the topic for the demo class today. Shock. If you got any doubt, you can contact Bluepen, and he'll contact me directly. And you can give a review of the class today. And if you're interested, we can continue this class in the forward. Anyway, thank you.